Good afternoon, everyone. Today in our urology Viva exam preparation, we are going to discuss the scenarios on bladder cancer. Thank you for the trainee who has agreed to record this procedure, which will be a good revision and learning source for the future batch. Your time starts now. You have a 58-year-old gentleman presented with history of visible hematuria in your hematuria clinic. How are you going to treat him?
So I will assess this patient in a one-stop hematuria clinic with a cancer specialist, where I'll take a history, examine the patient, arrange some investigations, including a flexible cystoscopy. In my history, I will confirm the duration of this hematuria. I'll ask about associated lower urinary tract symptoms, if there's been any recurrent or associated urinary tract infection. I'll ask about any signs of anemia, such as tiredness, symptoms of metastatic disease, such as weight loss. I'll ask about risk factors for urothelial cancer, such as smoking or exposure to chemical dyes. I will document his past medical history, medication history, including anticoagulation. And I'll offer a chaperone and examine this patient. I'll examine his abdomen for any palpable bladder, examine the genitalia, and do a rectal examination to assess the prostate for any abnormalities. Following on from this, I'll send some urine for urine dip cultures, as well as cytology. I'll take bloods for full blood count using his clotting, and after appropriate counseling, I'll send off PSA as well. I will then discuss a flexible cystoscopy with the bowels information leaflet and proceed with this investigation. I would also arrange for upper tract imaging. Given that this is visible hematuria and is 58, I will go for a CT urogram if he has a normal kidney function.
Okay, you said 58 age to be considered when you are planning CT urogram. Why is that?
Yes. So the Royal College of Radiology guideline advises that below 40 years of age to go for an ultrasound scan, but if they're 40 and above, to go for a CT for visible hematuria.
Why is that?
This is because of the radiation dose and associated risk of cancer. So the older the patient, the more likely they're going to have a urothelial cancer. Also, if a patient has a high radiation at a young age, then the risk of developing radiation-associated cancer is higher for younger patients. So these are the considerations.
Okay, so you are performing flexible cystoscopy, and cystoscopy picked up 2 centimeter papillary lesion in left lateral wall. Do you think you can improve the efficiency of your normal flexible cystoscopy by any means?
So the efficiency or pickup rate of a flexible cystoscopy can be improved by photodynamic cystoscopy or blue light cystoscopy or narrowband imaging.
Okay, what do you mean by photodynamic cystoscopy?
So this involves administration of 5-aminolevulinic acid or 6 or hexalevulinic acid an hour before cystoscopy, and introduction of blue light at a wavelength of 375 to 440 nanometers, and the abdominal urothelium will appear red on cystoscopy.
Okay, what about narrowband imaging, how it works?
So narrowband images uses a particular band of light for cystoscopy, and also abnormal urothelium will appear differently, but I'm not exactly sure what the color changes with the narrowband. Okay.
Now, as I said, this patient has 1.5 to 2 centimeter papillary lesion in the left lateral wall. Both the ureteric orifices were normal. How are you going to proceed?
So I'll counsel this patient with a Macmillan nurse specialist, explain that there is a lesion in the bladder suspicious for a bladder cancer. I will explain that he requires a transurethral resection of bladder tumor to remove the tumor, but also yield tissue for histological analysis. I'll counsel him regarding this procedure with the bowels information leaflet, discussing the risks, benefits, and alternatives, which in this case, there isn't really much alternative. I'll discuss the risk of infection, bleeding, bladder perforation with this patient. I would also advise that we will administer post-operative mitomycin to reduce the risk of recurrence. If this patient is agreeable, I will add them to the list for a TURBT. I would also take the opportunity to request upper tract imaging in the form of a CT urogram.
Okay, his CT urogram is normal. What is the evidence of mitomycin?
So a meta-analysis by Sylvester et al. Showed that with the post-op administration of intravesical mitomycin, there is a relative risk reduction of 39% of risk of recurrence, absolute risk reduction of 12, and absolute risk reduction of 8.5, and a number needed to treat of 12.
Okay, so how will you give mitomycin? Let us assume that you are doing a monopolar TURBT. The resection went well. How will you give mitomycin?
So mitomycin is given immediately post-op. It's reconstituted with 40 milligrams of mitomycin in 40 or 50 mils of saline, and it comes in a closed system, which is instilled into the bladder. With all the cytotoxic measures of PPE applied, and it's left in the bladder for an hour and emptied.
Okay. What precautions you will inform the team in the recovery?
So I will inform them that this patient has a cytotoxic drug. It needs to be disposed in a cytotoxic bin with appropriate personal protection, in the form of gloves, apron, and visors to be worn before draining and emptying this mitomycin.
Okay. His histology is G2 high grade pTa TCC with muscle present in the specimen but not involved. How are you going to treat him?
So, according to the NICE risk stratification, this is the intermediate. This qualifies as intermediate risk, and this. So I will discuss him in the MDT. An MDT will likely recommend, given that there is good muscle specimen, which is clear of tumor. MDT will likely recommend a 6-week course of intravesical mitomycin to reduce recurrence.
So what is the evidence behind that?
So again, this comes from the meta-analysis from Sylvester.
Okay. So how are you going to arrange further follow-up for him?
So the follow-up of this patient, given that it's intermediate risk, will involve following the administration of mitomycin. It'll be flexible cystoscopy at 3 months, and then 6 months, 18 months, and annually after that.
So how long you're going to follow up him?
For up to 5 years.
Okay. So when the patient comes for review, is there any difference in your approach compared to the normal flexible cystoscopy? Anything you need to do more, or what is your aim during the first flexible cystoscopy review?
So my aim in the first flexible cystoscopy is to carefully look for any evidence of recurrence. This patient would also benefit from urine cytology as well to look for any abnormal cells. And so I will perform a cystoscopy as well as send off a urine cytology for this patient.
Okay. How this cytology works? What are you looking for in cytology?
So cytology works on the principles that abnormal high grade or bladder cancer cells are shed in the urine, and this will be analyzed under the microscope, looking for cellular features of malignancy such as ATPA or raised nucleocytoplasmic ratio to categorize if the cells are abnormal or not.
Okay. What do you mean by papillary urothelial neoplasia of low malignant potential?
So this term came in following the most recent classification of urothelial or grading of urothelial cancer by WHO, and it is the lowest risk of abnormality of bladder cancer.
Okay, good. So it's time's up now. Well done. Basic scenario, box standard. You have done the same scenario with us before. So nicely done. No major concerns. You have picked up the risk factors like smoking, and the few things what I can say is sending urine dipstick and urine culture. You just said in one breath. Urine culture only if urine dip is positive. If urine dip is negative or normal, no need for urine culture.
Okay.
Yeah, you are correct with age cutoff was 40. So less than 40-year-old. Number one, chances of finding urothelial cancer is less. Number two, we don't want to expose them to radiation, which will have long-term effect for a young patient. So that's why we prefer ultrasound. Of course, if ultrasound is abnormal, we will go ahead with CT scan. Read about neuroband imaging. Better to bring out the nanometers and various wavelengths, etc., like how you have said for the green light cystoscopy. 40 milligram mitomycin in 40 ml of normal saline. You said 40 or 50 ml of normal saline. Just stick with 40 ml of normal saline.
Okay.
Like any other mitomycin in the follow-up, you can keep the mitomycin post T or BT for 2 hours. And if the patient is nicely awake and able to tolerate, you can ask the patient to change the position every 30 minutes, more the merrier. Because we are not aiming only the T or BT scar, we want the mitomycin to touch the full mucosa, including the dome. So 2 hours with rotations if possible, especially early T or BT, it's quite difficult, but if possible. And as you said, warn the recovery team that this is cytotoxic drug, and you should bring in the purple topped yellow disposable bins. That is the code for here. Usually I think it's international, so it should be the same all over.
Okay.
Good. Happy to start for the second scenario?
Yes, please.
Okay. Your time starts now. You have a 70-year-old gentleman presented initially with visible hematuria, had a flexible cystoscopy showing a bladder lesion, subsequently had TU or BT. TU or BT is reported as G3pT1 TCC of the bladder with CAS. This is discussed in MDT, you are discussing it. So how will you discuss it further?
Okay, so this, from the information I have, this patient has a high risk bladder cancer. The MDT will likely recommend a resection, TURBT, at 4 to 6 weeks to confirm that there isn't any upgrading or upstaging of this tumor. So that will be the initial recommendation of the MDT.
Okay. Why repeat T or BT? What is the evidence behind that?
So the evidence shows that following a repeat TURBT, especially for high-grade bladder cancer, there is incomplete resection in up to 40% of the cases. And for PT1 bladder cancer, there is a potential of upgrading to muscle invasive in up to 20% of the cases.
Okay. And what is other plans if the histology comes negative in the re-resection?
So if the histology comes back negative or confirms superficial bladder cancer, then the management options for this patient, especially for a G3pT1 plus CIS, include intravesical Bcg therapy in line with LAM's regimen, but also because this is a high-risk cancer with risk of progression, there is also an option for an upfront cystectomy in this patient.
Okay, can you explain the LAMPS regimen?
So LAMPS regimen involves an induction course of BCG 6, and then a 6-week break, and further course of 3. And each course is 1 course a week, and then intervals of 6 months with 3 courses up to 3 years, giving a total of 27 installations of BCG.
Okay. What is your view on a patient's tolerability of the BCG? How much of patients can complete the full course? And if the patient is not able to tolerate BCG, what is your advice?
So the BCG intolerance is one of the potential downsides of BCG. If a patient cannot tolerate BCG, then a consideration of whether they've had an effective dose, which would be 5 out of 6 of the induction, or 3 out of 2 of the initial maintenance. So this will be considered. If, however, they completely cannot tolerate BCG, there are all other potential treatment options, such as hyperthermic mitomycin or electromotive mitomycin, but this needs to be done at specialist centers.
How does electromotive mitomycin works?
So electromotive mitomycin works on the principles of using polarized electrical potential to increase the penetration of mitomycin into the urothelial cells.
What about hyperthermic mitomycin?
So hyperthermic mitomycin involves instilling mitomycin at a higher temperature, I think 40 degrees Celsius or 50 degrees, I'm not exactly sure. But this is thought to also improve the penetration and the efficacy of intravesical mitomycin.
Okay. Do you aware of various types of BCG failure, like BCG resistance and BCG relapse? Do you aware of them?
So BCG resistance is defined as persistence of bladder cancer following the initial induction of BCG. The histology of the persistent tumor does not progress, but could be of the same grade or less. BCG refractory means that the patient has BCG, and despite this, there is evidence of histological progression of the tumor, whereas BCG relapse means recurrence after completing a course of BCG.
Okay, so what is BCG?
So BCG stands for Bacillus calmette guerin, and this is a live attenuated Mycobacterium bovis. It works on the principles that when BCG is instilled into the bladder, it's incorporated into the urothelium by the fibronectin receptor, bringing about immunological response and reaction in the bladder that leads to destruction of cancer cells. The evidence is that this prevents recurrence, but more importantly, prevents or has benefits in terms of preventing progression of bladder cancer.
Okay. After the BCG installation, this patient developed significant dysuria and frequency. How can you help him?
So such side effects from BCG, if a patient develops that, it's important to exclude a urinary tract infection. So I'll send off urine for culture, and if there's any evidence of UTI, to treat that episode. I'll advise the patient to increase their fluid intake to keep the urine dilute. and empty their bladder regularly. These conservative measures may actually be what the patient requires to manage the symptoms.
Okay, and by chance, if the patient has no improvement and there is no signs of any infection in the urine, any other measures?
I'm not exactly sure of any other measures apart from the conservative ones.
Okay, the patient which you have treated successfully had the induction course of BCG and the maintenance for 1 year. After 1 year, there is a recurrence of lesion in the floor of the bladder. The resection showed G2 high grade pTA. How are you going to proceed?
So I will rediscuss this at the urology MDT. And given that this is a lower grade compared to what it was before, MDT will likely recommend to carry on and complete the course of maintenance BCG.
Okay, we will stop there. How do you think you did?
So I think I progressed well. I hope I got through to the end of the station.
Yeah.
The BCG, and it's a very topical issue with urology. The definitions, sometimes I do confuse them, but I hope I got them right in terms of relapse, refractory, and BCG failure.
Yeah.
But overall, I think I answered the questions appropriately.
Yeah, correct. I think for this high risk non-muscle invasive bladder cancer, you did much better. No major concerns. The best place to refer the BCG types of failure is the EAU guidelines. It's very nicely described.
Yeah.
And LAM regimen, Sylvester trial, everything is very nicely done. And for the BCG cystitis symptoms, you can start anticholinergics or mirabegrone. Nothing wrong in that. Lifestyle changes. If the patient still smoking by chance, avoiding smoking, decaffeinated drinks, appropriate hydration, avoiding constipation, all the normal things, and then nothing wrong in starting with, say, sulfasalazine. And if the patient is not able to tolerate, or if there is no improvement, maybe mirabegrone. And when you're doing a flexible cystoscopy, you can try to access the volume of the bladder, even though we tend not to overfill the bladder, especially in flexible cystoscopy. If the patient attends for any GA cystoscopy like TRBT or GA cystoscopy biopsy, that's a good time to assess the bladder volume and document it. So if the patient develops BCG cystitis, we can correlate, is it just due to the irritation or the BCG changes in the mucosa, or is it due to the low volume in the bladder or loss of bladder capacity?
Yeah.
Good. Happy for another scenario?
Yes, please.
Good. Your time starts now. You are sitting in an MDT. A 65-year-old female presented with history of smoking and visible hematuria. Flexible cystoscopy showed a solid bladder lesion. Subsequently, she underwent uneven full TURBT. The histology is G3pT2 TCC of the bladder with muscle involvement, obviously. And she's quite fit otherwise. So how are you going to proceed?
So I will see this patient in a specialist bladder cancer clinic with a nurse specialist and explain the outcome of the MDT and the histological results confirming a muscle invasive bladder cancer. I'd like to know the full staging results of this patient. If she hasn't been staged, she requires a staging CT thorax abdo-pelvis to exclude any metastatic disease. Okay.
So what kind of imaging you are arranging?
CT thorax, abdomen, and pelvis.
Okay.
With a urographic phase.
Good. Her staging is normal. How are you going to proceed?
So in the absence of any evidence of metastasis, this lady has muscle invasive bladder cancer. She's 65. She's a very fit lady. And so the MDT will recommend a radical treatment option for this lady in the form of neoadjuvant chemotherapy plus either radical cystectomy, which can be done robotically or open, or radical radiotherapy.
Okay. She wished to discuss the bladder preserving strategies. What is the role of it?
So the role of bladder preserving strategy is mainly radical radiotherapy, which is at clinical equipoise with cystectomy. The specifics of this will be discussed by the oncologist who gave radical radiotherapy. However, I can tell the patient that this will preserve her bladder. There is a potential risk of radiotherapy effects to surrounding organs like the bowel, resulting in diarrhea or radiation proctitis. She will require ongoing cystoscopy surveillance following the initial treatment. So this would be the main things to discuss with her for the bladder preserving strategy.
Okay. After understanding the pros and cons, she is happy for radical cystectomy. How are you going to prepare her?
So I will counsel her with the aid of a Bowles information leaflet. I'll explain to her that radical cystectomy involves removal of the bladder. This also involves pelvic lymph node dissection, as well as urinary diversion, which could be a continent urinary diversion or an incontinent urinary diversion. I will explain to her the risks, including infection, bleeding, damage to major pelvic vessels, risk of urinary leak or lymph leak or lymph collection, risk of bowel injury due to anastomotic leak, which may require major laparotomy down the line. I'll explain the risks of anesthetic risks, and given that this is major surgery, risk of clots in the legs, clots in the lungs. However, she will have a session with the anesthetist as well to discuss in details about this. I would also make sure that she has a session with my cancer nurse specialist and the stoma nurses to discuss stoma care and go through sessions before the operation proper.
Do you aware of enhanced recovery protocol? What is the role in radical cystectomy?
So enhanced recovery protocol is a protocol which is in place now for major surgery across all surgical specialties. From a urology perspective, this involves optimizing this patient preoperatively and ensuring that the patient commences physical activity as soon as possible after surgery, and also instigating early introduction of diet following surgery. So it's a process to ensure the best outcome following major surgery.
Okay. How will you prepare her from the cardiology and pulmonary point of view?
So from a cardiology and an anesthetic perspective, a careful anesthetic review as well as a Cpex testing assesses this patient's suitability for major surgery. And depending on this, recommendations will be made either for this patient to go to high dependency units or indeed to avoid major surgery if they're not fit enough for it.
Okay. What is the Cpex testing which you mentioned?
So this stands for cardiopulmonary exercise testing, where a patient attends and usually goes on an exercise bike, and the oxygen requirement and CO2 production is calculated. An anaerobic threshold is also calculated for the patient, and all these parameters are interpreted to assess fitness for surgery.
Okay, so you are preparing her for surgery. So what is your major steps in the surgery?
So this will depend on if it's open or robotic. I am familiar with the robotic cystectomy approach with ileal conduit urinary diversion. So this patient will, in an appropriately prepped and anesthetized patient, patient is kept in a Trendelenburg position up to 30 or 35 degrees to move the bowel away from the field of surgery. The ureters are identified and the bladder is dissected out. and given that she is a female, the anterior vagina goes as well with the bladder. Following on from that, pelvic lymph node dissection is performed, and then an ileoconduit is formed where a piece of distal ileum is isolated and anastomosed to the ureters, and the terminal end is brought out as a urostomy or a stoma.
Which part of ileum you will harvest?
So I will isolate, I'll measure 15 centimeters from the ileocecal junction and isolate a 15 centimeter segment of terminal ileum.
Why is that?
So preserving the most distal part of the terminal ileum is important because that is the point of absorption of important minerals as well as vitamin B12 and iron.
Okay. Regarding lymph nodes, how much you are going to dissect?
So the boundaries for pelvic lymph node dissection in cystectomy include external iliac group of lymph nodes, obturator group of lymph nodes, internal iliac, and the presacral.
Okay. Do you know various types of lymph node dissection?
So there is the standard and extended and super extended levels of lymph node dissection. What I've mentioned is the standard. The extended may go up to the bifurcation of the aorta, and the super extended goes up to the abdominal aorta.
So when will you plan extended or supra extended lymph node dissection?
So if the imaging suggests a lymph node outside the true pelvis, then one may consider an extended or super extended lymphadenectomy. However, the consideration if there is lymph node extension to this point is whether surgery is now curative, and it should be carefully discussed and decided in MDT before going for that.
What is your view on orthotopic neobladder in women?
So, orthotropic neobladder can be considered if the patient is young and doesn't have any contraindications, for example, impairment in kidney function or previous significant incontinence. So if in the absence of these contraindications, orthotropic neobladder can be considered in women, they need to be motivated to perform self-catheterization after the procedure and have the dexterity for that as well.
Okay, so how will you construct the orthotropic neobladder?
So this is done with a 60s. I am familiar with the Tudor technique, which involves isolating a 60 centimeter segment of the distal ileum after preserving the most distal 15 centimeters, detubularizing it and creating a neobladder, which is anastomosed to the urethra as well as to the ureters.
Yeah, the time is over now. So you can explain that there will be a chimney constructed in which the ureters are implanted, which will avoid a little bit of ureteric reflux also. Well done. Again, this is the advanced stage of the bladder cancer presentation. The other contraindications of orthotropic neobladder is the patients with hydronephrosis, patients with hepatic dysfunction, and also patients who have bowel disease like Crohn's disease or ulcerative colitis, that has to be included. And the terminal ileum, vitamin B12 along with minerals. B12 is more important compared to minerals. And enhanced recovery protocol, again, more of mobilization and early morning glucose challenge that has proven to reduce the unnecessary, it gives the enough raw material for the metabolic challenge what the patient is going to head on. And the removal of the nasogastric tube early, DVT prophylaxis, mobilization which you mentioned. Cpex, I think if I'm correct, I asked you and then you brought in. So try to bring in Cpex as a part of on a non-recovery protocol as a part of your pre-op preparation directly.
Okay. Yeah. Yeah.
This group of patients, when you're discussing histology in the MDT, G3pT2 CIS, it is nice if you ask the pathologist to do PDL1 staining.
Okay.
That will be useful for any neoadjuvant immunotherapy. We haven't discussed neoadjuvant chemotherapy because of lack of time, but it will be also useful in future in case if the patient is having a recurrence or presenting with metastasis. PDL1 staining of the initial TURBT specimen will be very handy. These kind of answers will really make the examiner to think, okay, you have sat in the MDT and you have made the decisions also.
Yeah.
Good. Well done.
Thank you.
And orthotropic neobladder in women is not straightforward compared to men. Again, the contraindications are like tumor in the bladder neck, involving the urethra, etc. Patient should be aware of need for intermittent self-catheterization, as you mentioned, G3. The main thing is the urethra is not as supportive in a woman compared to men. That's why neobladder orthotropic is challenging. And if you say robotic, there are people who are now advancing towards creating orthotropic neobladder robotically, but you can say, I will do the radical cystectomy part and then make a small incision to reconstruct the neobladder or for the ileal conduit. Yeah. Good. Any things you want to add?
No, I think you've introduced the more advanced ones, which is actually helpful to discuss them because, and would I be fair to say that the exam can actually go that far?
Yes, definitely. What we have discussed today is definitely exam questions. In fact, there will be more questions on neoadjuvant chemotherapy, advantages and disadvantages of that, advanced bladder cancer trial, and maybe like neoadjuvant immunotherapy also, because it's quite nicely evolving. There may be some questions on CIS. What is CIS? Why CIS is different from TCC? Why it is important? And response of CIS to BCG will be discussed separately.
Yeah, it's very useful, very good session actually. Because bladder cancer is especially when it goes to the muscle invasive one. A lot of discussion can be generated, as you clearly did now. So thanks for that.
Yeah. The other things in the MDT is you should go through the operative notes to make sure the surgeon is happy that the lesion is completely resected, because there is a good evidence that even though it is G3pT2 muscle invasion proven, if there is a residual disease, it is advisable for patients to have a TURBT, whether the patient goes for radiotherapy or neoadjuvant chemotherapy with radical cystectomy. And there are studies which have proven that a good TURBT with neoadjuvant chemotherapy and radical cystectomy, especially if the radical cystectomy shows no cancer, those patients will have excellent outcome, because we are going one step above what is involved. You need to think like how we do for pineal cancer, lymph node involvement. If the lymph node is involved to one level, we'll try to dissect one level up. And then if that level is involved, we need to go for the one level up till we get the normal lymph nodes, like that. So if the TURBT itself clears the tumor, and then if you do a radical cystectomy, that means the patient's cancer clearance and cancer specific survival and overall survival both will be much better. Good. Well done.
Thank you.
Good. Thank you for joining today. Hopefully we will do one more interesting table in the next few days. I will send you the WhatsApp message.
All right. Thank you very much. Bye-bye.
Welcome.